So I'm just going to be very brief. Don was kind enough to ask me to just give a brief introduction to POEM, which is per oral endoscopic myotomy, which is a relatively novel endoscopic approach to the treatment of achalasia. I think for those of you who are familiar with the NOTES, or the natural orifice transluminal endoscopic surgery movement that sort of hit a hysteria between about 2005 and 2009, and I'm not sure NOTES will ever be part of clinical practice. It's certainly not currently part of clinical practice, but one of the advantages of NOTES, one of the benefits of that movement, at least from a research standpoint, was the recognition that we can create a working space within the submucosa of the wall of the GI tract. And I think the maturation, or the sort of research in NOTES concurrent to the maturation of endoscopic submucosal dissection, which is a also relatively novel approach to resecting superficial lesions of the GI tract, has made it clear that we really can take advantage of the submucosal space. And in this very nice review article by Jay Pashrisha, who was just mentioned a little bit earlier, a lot of different potential applications have been proposed, including implanting neurostimulators and harvesting tissue for stem cell research and applications have all been proposed. But I think one of the most sort of immediately clinically applicable approaches to submucosal endoscopy has been the reshaping of anatomy in the form of myotomy. And so POEM, or as I mentioned, per oral endoscopic myotomy, has been proposed as a fully endoscopic treatment for achalasia and other motility disorders of the esophagus. And so the concept is actually pretty genius if you think about it. Using a flexible endoscope, you can actually gain access into and expand the submucosal space. And when you do that, you can create a tunnel within the submucosal space. So on one side, you have the actual mucosa. This is the true lumen. This is the mucosa. This is the pseudolumen. And then once you've created that tunnel, then it's exposed the actual deep muscle of the wall of the esophagus. And once you have access to the deep muscle, then you can use a multitude of different endoscopic instruments to transect or incise that muscle, thereby performing a myotomy. And in practice, this was proposed primarily as an approach to transect the circular muscles of the circular muscle of the esophagus wall, thereby leaving the longitudinal muscle and the serosa. But once you're done with that, then all you have to do is close this entry site, which is called the mucosotomy, re-establishing a barrier between the lumen of the esophagus and the mediastinum. And so in this way, you could actually perform a myotomy endoscopically. So these are some endoscopic images from a POEM. This is an endoscope that's actually within the submucosal tunnel. This is just a clear cap that's been attached to the tip of the endoscope. And as you can see, the way we expand the tunnel is by injecting blue colored saline, so saline that has some blue dye in it, and that's what the blue appearance is. But on this side right here is the mucosa, and so if you were to perforate through here, you'd actually end up in the lumen of the esophagus. And what you see here, the sort of lighter colored stuff, are actually muscle fibers. So we're seeing the circular muscle of the esophagus wall, which you intend on transecting to perform the myotomy. In this top right panel is an example of that, where they're using what's called a hook knife, which is a sort of a new age needle knife type instrument for this purpose and for the purpose of ESD, to basically capture these circular muscle fibers and transect them. And once you've done that longitudinally, then you should be theoretically left with the longitudinal muscle fibers that you don't see, but at least the serosa. And you can extend this myotomy as far up as you think is clinically necessary. And this is one proposed advantage of POEM over Heller myotomy that's done laparoscopically. You can extend, the myotomy is very flexible. You can extend it up as high as you need to treat mid-esophagus motility disorders, etc. But once you've done your myotomy, then all you have to do is use endoscopic clips to close this mucosotomy, and you've reestablished the barrier. So this is not my video, but it's a very nice illustrative video from Lee Swanstrom's group, which basically demonstrates the process of initially creating a space within the submucosal plane by a typical submucosal injection. Then they're using a needle knife to create an entry point or a mucosotomy into the submucosal space. And they're going to literally advance the tip of the endoscope into that submucosal space and then dissect the submucosal fibers. Here they're using an ERCP extraction balloon to create a blunt dissection. Here they're using just a catheter to bluntly dissect, and essentially all you're doing is you're taking down these submucosal fibers, which are very areolar and amenable to dissection, in order to create that tunnel and expose the muscle. And so this is just sort of an additional example of blunt dissection. And once the submucosal tunnel is done, then you can see these circular muscle fibers, which in this case they're using something called an insulated tip knife to actually just transect through those circular muscle fibers. Now, recently people have moved to actually performing full thickness myotomy, and it turns out that the mucosa in and of itself, as long as it's intact, will prevent a clinically relevant perforation in and of itself, which is sort of a novel concept. But in either case, they're using a multitude of different instruments to basically transect through that circular muscle. And then once that's done, you should be left with just longitudinal muscle and serosa. You can pull out of that submucosal tunnel and then use endoscopic clips to close the mucosotomy. And so to date, at least over 2,000 POEM procedures have been performed worldwide. On the basis of short-term, sort of 3-month data, it looks like the clinical response rate is in excess of 95%, with a very low risk of serious complications, and purportedly there have been no deaths thus far, knock on wood. Initially, POEM was proposed as a superior treatment for achalasia compared to Heller myotomy because, first of all, you leave, in general, the longitudinal muscles, plus you leave the angle of His intact. And so it's thought to perhaps be advantageous in terms of reflux. That doesn't turn out to be the case, but certainly POEM is associated with shorter hospitalizations. And I bet that there will be a time where we'll do POEM exclusively as an ambulatory procedure. So I think that's going to be a major advantage. But the question that comes up, and I agree 1,000% with Don on this, is that we basically have no comparative effectiveness data evaluating POEM versus established modalities. And so POEM is a very elegant procedure. It's very gratifying as an endoscopist. When you do a balloon dilation, you hope that you've torn enough muscle, but not too much. And so you're left with a little bit of uncertainty. When you leave a POEM, you know with 100% certainty that that muscle is gone. And there's something very elegant and gratifying about that process. However, POEM can take 2 or 3 hours to do. There's a risk profile that we probably don't yet understand. It's resource intensive. On the flip side, a balloon dilation takes really 1 minute, or with the whole process less than half an hour. The complication rate is reasonable, and now that we're comfortable managing our own perforations endoscopically, the complication rate is going to prove to be even lower, and it works very well. And based on my conversations with Don, it appears to be very durable. And so those of us who are jumping on the POEM bandwagon really need to take a step back and really consider the merits and disadvantages of a proper randomized trial to compare POEM versus pneumatic dilation, in this sort of really intriguing area moving forward.